thank you all for the opportunity to share our work on behalf of the Outcomes Committee. To start us off, we had a few poll questions or scenarios to frame our presentation. They're available on the app, but just in the interest of time, I'm just going to ask for a quick raise of hands in response to these scenarios if you would offer this patient a cholecystectomy. You have a 15-year-old girl who was referred to you by Peds GI, and she has typical symptoms of biliary colic, but otherwise her workup is unremarkable. She had a HIDA scan with a gallbladder ejection fraction of 25%, and she has replication of her symptoms with CCK administration. Just show of hands, who here would offer a cholecystectomy to that patient? Okay, kind of split in the room. All right, we're going to change the scenario up. Same patient. The difference here is that the pain she endorses are not typical of biliary colic. Again, otherwise the workup is unremarkable, and her HIDA scan shows an ejection fraction of 25%. And again, she has replication of symptoms with CCK administration. Who here would offer that patient a cholecystectomy? Okay, so smaller proportion. Flipping the script, same patient, symptoms of biliary colic, but on her HIDA scan, the ejection fraction is 55%, and she has replication of symptoms with CCK administration. Who here would offer that patient a cholecystectomy? Even smaller proportion. Okay, and final scenario, 15-year-old girl, typical symptoms of biliary colic. She has a HIDA scan with an ejection fraction of 90% and replication of her symptoms with CCK administration. Who here would offer this patient a cholecystectomy? All right, a few of the proud, okay. So as I'm sure you've all witnessed in your practices, cholecystectomy for biliary dyskinesia is on the rise. In recent studies, it's accounted for up to 50% of the cholecystectomies being performed in the pediatric population in North America. Interestingly, as a pathology, it appears to be diagnosed at a much higher frequency here in North America compared to other countries around the world. Yet despite this rise in diagnosis and cholecystectomy, the pathology itself remains pretty ill-defined in pediatrics. This is in distinct contrast to biliary dyskinesia in adults, where efforts such as Rome-4 have defined it as a functional gallbladder disorder. And briefly, Rome-4 is an academic collaboration, mostly adult-centered gastroenterologists, that have developed guidelines around functional GI disorders. The guidelines are released every 10 years, and the last one was Rome-4 in 2016. And we can see here the level of detail involved in defining what exactly constitutes biliary pain, the role of ejection fraction merely as supportive criteria, and the absence of things like postprandial pain as part of the presentation. The Rome Foundation does have a pediatric working group with recommendations, and while there's no defined biliary pain disorder in children and adolescents, there are several other defined abdominal pain syndromes that share some overlap with symptoms of biliary dyskinesia. So just to review our methods, the Outcomes Committee, through a Delphi process, generated 5 a priori questions. They included, what is the evaluation and diagnostic criteria for suspected biliary dyskinesia? When is cholecystectomy indicated for biliary dyskinesia? What are the short and long-term outcomes from cholecystectomy? Are there clinical laboratory or radiographic predictors of symptom resolution? And what are the outcomes of medical management or observation? We used the PRISMA guidelines to help organize our systematic review. We reviewed studies from 1966 to 2021. We included studies with a mean or median age less than or equal to 18 years. And at the end of this process, 82 studies were found to be suitable for inclusion in this review.
Okay, so for question 1, we're looking at what is the evaluation and diagnostic criteria for suspected biliary dyskinesia in children. And so for this question, we really looked at these publications to see if they actually had novel diagnostic criteria that was different than the Rome-4 criteria for adults. We reviewed 82 articles overall, and only 3 had novel diagnostic criteria for children. All of these studies had less than 30 patients in each of them. The first, in K et al., used a fatty meal stimulation and gallbladder with a gallbladder ultrasound as part of their diagnostic criteria. And then 2 others used HIDA scan with either Syncolite or Lipomule, so non-CCK agents as part of their diagnostic criteria. So overall, there was very few data. So we could not really draw any conclusion that there was any pediatric specific criteria for biliary dyskinesia. So for question 2, we looked at what was the indication for cholecystectomy for biliary dyskinesia in children. So looking at the method section, what did they say, what their criteria was? We had 29 studies overall. All of these were retrospective. 25 had a low EF and 4 defined hyperkinesia. There were about 1,465 patients. Most of these studies describe the indication in terms of EF, symptoms, and lack of gallstones on ultrasound. So most of these studies, 20 overall, use an EF of 35% as criteria for cholecystectomy. 22 studies had most of their patients undergo an ultrasound to evaluate for stones before they would do a surgery. 9 studies discussed pain with CCK, but only 4 studies actually used that as part of their diagnostic criteria. And there were 4 studies on hyperkinesia that used either an EF of 65% or 80% as part of their criteria for surgery. So in conclusion, most studies use biliary symptoms, normal ultrasound without gallstones, and EF less than 35% as an indication for cholecystectomy in children. There was much smaller evidence base describing the operation for biliary hyperkinesia. And both these were level evidence 4.
So next we decided to look at what are the short and long-term outcomes after cholecystectomy in children diagnosed with biliary dyskinesia. Probably most importantly, is this a safe thing to do? We looked at 23 studies, 1,760 patients. In general, these are on the easy side of gallbladders, not a whole lot of inflammation. These are pretty safe. There was only 1 common bile duct injury and 2 major bile leaks. So next, we looked at outcomes. So we divided this into short-term, sort of perioperative under 30 days, and then long-term, which was over 6 months. So for the short-term data, studies defined getting better in different ways. Some defined it as resolution, some defined it as partial improvement. As sort of like the top line, bottom line data as they reported it, 75% of patients got better in the short run on a meta-analysis we did with 1,890 patients. If you split it out to studies that sort of qualified it by partial or complete resolution, up to 89% had partial resolution, but only 65% had complete resolution. So this could actually inform the way we counsel patients that maybe we don't have to hit it out of the park, but maybe we'll get you a little bit better. The long-term data was about the same, 73% as reported, including partial resolution was 77% and complete resolution was 63%. And this was 790 patients here in 24 studies. So in conclusion, there were a very low rate of complications for laparoscopic cholecystectomy for biliary dyskinesia in children. And somewhere between 60 and 80% of patients that are diagnosed with biliary dyskinesia will get better after the cholecystectomy.
So we wanted, the question 4 is looking at whether or not there are better ways to predict symptom resolution in patients after cholecystectomy. Most of the studies only included patients with EFs less than 35%. There was almost no comparison groups of EFs higher than that. So there's insufficient data to determine if EF under 35% is itself an appropriate predictor of symptom resolution. Looking at the studies that were available, there were 16 additional studies, 16 studies that did further analysis of EF looking for a lower cutoff. Only 3 of these studies reported some association of a specific EF number with relief. But 13 of 16 studies were unable to identify any EF cutoff or EF association with symptom relief after surgery. When we were looking at symptomatology with CCK administration, there were 8 studies overall that mentioned pain with CCK. 7 of those studies did further evaluation to see if there was a correlation between the two. 0 of 7 studies found any association between CCK administration pain and symptom relief after cholecystectomy. A few papers identified myriad other factors associated with either short or long-term symptom improvement or persistence of symptoms post-op. Most of them were not replicated amongst the studies, excepting perhaps, you see highlighted here, shorter duration of symptoms. There were 4 studies who looked specifically at hyperkinesia, which is defined as greater than 65% in 2 studies and greater than 80% in the other 2. All included typical biliary symptoms as an inclusion criteria. They were all retrospective, all descriptive, and without formal analysis for EF association. So the data is not statistically robust. But when you combine the numbers, see that anywhere from 80 to 89%, depending on how you cut off the EF for hyperkinesia, have some relief of symptoms after cholecystectomy. So in conclusion, there's minimal data assessing the outcomes of patients with a normal EF. The severity of EF derangement doesn't predict symptom relief in most studies. Symptomatology with CCK does not predict symptom relief. Shorter of duration of symptoms may correlate with symptom relief. And 80 to 90% of children with EF greater than 65% and typical symptoms have some relief of symptoms after cholecystectomy. That's level of evidence 4. Since we've talked, most of the focus so far has been on cholecystectomy. Question 5 focuses on the outcomes of medical management or observation for these patients. We have 6 studies with 71 patients that reported outcomes of non-operative management. They were all retrospective with a moderate to high risk of bias, and most without formal comparison data or statistical analysis. Again, less than robust data, but combining these numbers together, you can see that non-op rates of symptom relief in patients who were observed are relatively similar, or roughly equivalent to the ones who underwent cholecystectomy. So the conclusion for here is 76% of BD patients improved without cholecystectomy.
So our overall recommendations. First, there are no pediatric specific guidelines, but until they exist, we think it is reasonable to apply the Rome 4 adult-centered guidelines to diagnose and treat biliary dyskinesia in children. This is a grade D recommendation based on expert opinion. 2, in a child who's been appropriately worked up and you feel they have biliary dyskinesia based on typical symptoms, a normal ultrasound without gallstones, GI consultation, and supportive EF numbers, less than 35%, we think it's reasonable to either offer cholecystectomy or offer medical management or observation. This is a grade C recommendation. Next, in that same child who has biliary hyperkinesia, defined as EF greater than 65% or 80% in some studies, we think it is reasonable to also offer cholecystectomy to them, and that is grade D evidence, or grade D recommendation, sorry. And finally, we recommend that CCK symptom correlation should be abandoned. All the children's studies looking at this have shown no correlation. The adult literature is very similar, and there's an adult recommendation from the Rome Society to not use it as well. That's grade C recommendation. So, what do we do next? Well, we have cholecystectomy or observation with basically the same outcomes. We think this is a setup for a randomized controlled trial. There's a lot of patients. We think this should be done. Alternatively, some of our multi-center groups could probably study this in a prospective way because there was no prospective studies on this topic at all. Since we are recommending the use of the Rome 4 criteria and management protocol, we already looked at their diagnostic criteria, but in terms of management, they recommend to drag your feet. This will often respond spontaneously. You can try to just do observation, you can reassure patients, or you can try various medications. And this is mostly done by GI, not by surgery. You can consider cholecystectomy after non-operative management is not working. And they really emphasize that this should be a diagnosis of exclusion. The symptoms should be typical and severe, and you should have ruled out other causes with a thorough workup. Even then, you should counsel your patients that resolution is not assured. There's only one RCT in adults. It was small, about 20 patients, but it did favor cholecystectomy over observation, and it was 30 years ago. Rome 5. So we reached out to the pediatric Rome 5 working group, which is already starting to formulate recommendations. They anticipate publishing in 2026. So they say they are working on a pediatric biliary functional pain disorder guideline. Until then, most of them use the adult Rome 4 guidelines. Any questions? Actually, we'll wait for questions and we'll go on to the QSC.
Thank you. Dr. Ladd and I are happy to present on behalf of the ABSA Surgical Quality and Safety Committee on quality improvement in biliary dyskinesia. The main objective from our presentation today will be to demonstrate and highlight the use of the ABSA Quality and Safety Committee toolkit. Despite extensive review of the literature and personal investigations, there were no quality improvement projects on pediatric biliary dyskinesia that were able to be identified. However, we will present several quality improvement projects on pediatric biliary disease that exist in our toolkit. As well, we will highlight opportunities for future frameworks for QI projects on pediatric biliary dyskinesia in the future. So the ABSA Quality and Safety Committee Toolkit has already been mentioned several times at this year's meeting. If you were at yesterday's lymphatic malformation session or the real-world quality improvement implementation session, you may have heard the toolkit already mentioned. But my guess is there's still a handful of people in the audience who have never heard of the ABSA toolkit, and probably a larger number who have never actually gone to the Google homepage and accessed the toolkit. As an introduction to the toolkit is an expanding open access web-based repository of curated quality improvement projects. It was first created in 2019 and it is actively maintained by members of the Quality and Safety Committee. The goal of the toolkit is to facilitate knowledge sharing and the development and implementation of quality improvement projects. Pediatric surgeons are actually able to upload their institution's quality improvement projects directly to the website. As well, an annual review of the literature is performed by the Quality and Safety Committee members to try and identify published quality improvement projects that may be applicable to the topics included in the toolkit. The toolkit materials can easily be adapted to fit the needs of one's local institution. These materials contain evidence-based pathways, presentations to stakeholders, parent and patient educational materials, clinical support decision tools, as well as the contact information for the surgeon who developed the quality improvement project. So how do you get to the toolkit? Well, in addition to scanning the QR code that's shown, there's 3 easy ways to get to the toolkit. The easiest way to remember is just to Google search it. However, there's a link to the toolkit that's also provided on the ABSA website as well as on the Pediatric Surgery Library website. So as I mentioned, when you get back to your institution, if you're interested in implementing a project and want to look this up, simply type in the Google search bar, ABSA toolkit or ABSA QSC toolkit, and one of the first returns on your search is going to be the ABSA QSC toolkit. When you click on this link, you'll be taken to the toolkit's homepage. The toolkit itself exists on the Google Drive, and each of the topic buttons that you see here takes you to a link to a folder. Inside the folder are multiple QI projects that are pertinent to that topic and contain the materials that were listed earlier. You can see there's a wide number of buttons available. There's a wide number of topics represented in the toolkit. To get to this same homepage, again, you can visit ABSA's website. On the website, if you select resources and then Quality and Safety Toolkit. This will take you to that same homepage. Additionally, the material can be accessed through the Pediatric Surgery Library at Quality Improvement Toolkit. I mentioned that there's a wide variety of topics, and so there are folders on pilonidal disease, neck, gastroschisis, antibiotic stewardship, gastrostomy protocols, ARIS, CDH, appendicitis, SSI reduction, opioid reduction, and many other topics. And each of these topics contain multiple QI projects that have already been successfully implemented. Today, we hope to highlight one of our very newly established folders, which is the biliary folder.
So this is the current biliary folder as it stands, and as Katie mentioned, we have no quality improvement or evidence-based medicine trials around biliary dyskinesia. But we do have two areas of content that are in the current folder that I want to highlight here. But in use of the toolkit in general, what we recommend is always start with the README or the read first file that's within each of the content areas. This is a great place that summarizes all the content that's available and gives you a good overview of what's available to you. Within that file is the two listing projects that I don't expect you to read here, but basically there's the content that we have currently in this folder is around early recovery after cholecystectomy and results with regards to early intervention for choledocholithiasis as a surgery-first option. Highlighting the choledocholithiasis project. As you can see, there's numerous files here not meant to be read, but again, you'd start with the read first file, understand what's in this portion of the toolkit. It has the algorithm for treatment, it has the supplies needed in order to undertake this intervention, and the associated references and manuscripts associated with this project. So a great amount of material available to you if it's pertinent to what you're looking for. So how would you use the toolkit? Well, clearly if you've actually published in these areas, we value your input to upload that content, but we realize that we can be the good shepherds for your material and help you upload this content. So any member of the Quality and Safety Committee would be happy to help. We also do these annual reviews to make sure that these folders are up to date and timely. So we will often reach out to authors of new publications or manuscripts or any current or new material that we'll see within the abstracts of ABSA and try to obtain that information from you and see if you'd be willing to share it and place it into our QI folders for the Quality and Safety Committee. And then also, before you look at implementing new material at any one of your programs, please don't reinvent the wheel. See what's available within the toolkit that you can utilize to either implement or jump off of to make your work a little bit easier going forward. So again, with regards to biliary dyskinesia, we don't have directly identified QI projects for this. There's obviously wide variability in definitions, diagnostic evaluations, and treatments that clearly would be appropriate to be studied to develop that further evidence-based medicine compendium that we all desire. And it's an opportunity to try to standardize and improve our care going forward. With that, in the interest of time, I'll stop there, provide this QRS code for the toolkit, and then we can open up for questions.
Hi, Brad Warner, St. Louis. This is a great topic, and it really is something important enough that someone should take the initiative and initiate a funded randomized prospective clinical trial, because there's certainly enough patients that we see with these problems. One of the things, and I'm sorry I stepped out for just a bit and maybe it was mentioned, but I think in terms of the interpretation of the gallbladder ejection fraction, what I do in my practice is when I get patients referred to me and they usually have had one HIDA study and it's abnormal and so they get sent, what I always do is repeat it. And on repeat, it usually, if it was abnormal, is normal. And so I don't think that there are really good standards for what the EF ought to be in children, and it's quite variable when it's repeated. So if it's always abnormal and it's done so with more than one test, and I discuss cholecystectomy. I don't always offer it. I can't promise the resolution of symptoms, but I think repeating it is really important.
Yeah, we agree. The pediatric literature doesn't have anything on repeating HIDA scans that I'm aware of, but there are some adult papers on it, and it similarly showed that there was very poor correlation on repeat studies. The adult literature also emphasized that plenty of people with normal EFs get better after cholecystectomy for suspected functional gallbladder disorder as well.
Yeah, I think on top of that issue as well is there's a lot of variability in how HIDA studies are conducted and the timing of administration of medication and all of that. So all that certainly contributes to the variability in the results that they've been getting.
Yeah, this Tom Inge at Lurie Children's Hospital. That was one thing I was going to comment on. My many years at Cincinnati Children's Hospital, there was the great, grand poobah, you will, of nuclear medicine that would always say that the studies are done wrong most of the time when they administer the CCK as a bolus, and you get the child that's jumping off the table with right upper quadrant pain, and that the proper way to do it that is very reliable to determine whether the stimulant for gallbladder contraction is being done according to protocol. And I can't cite the protocol, I don't have it, but again, if you listen to senior advice, it is 30 minutes as a drip form. And so that kind of makes sense when you think about taking a meal and digestion and getting a payload into the duodenum. So that was just one of the other words of wisdom I wanted to share.
Romy Ignacio, San Diego. A great session. I knew nothing about biliary hyperkinesia, so it's great to hear about that. A couple of things. Have you guys looked at age groups? Because I find that younger age groups are a little bit more difficult to look at. I know what the literature says about that. I also have a dilemma with the atypical symptoms. You guys already had alluded with the literature, but the GI folks get really fixated on the number, and I'm like, they have atypical symptoms. I don't want to do an operation that's going to be some of a sham operation. What does the literature say of what is the adequate workup for those patients so that after all that negative workup, you can have a good conversation, just like Dr. Warner said, should I repeat that study? What's the expectation of what your kid's going to either improve or not improve? But again, great session.
Thanks. So as far as age, we didn't see any studies that stratified outcomes by age. Most of these patients are adolescents, as we all know. And as the second question, which was?
About age.
Atypical. Yeah.
Yeah, when we looked at the literature, there were a whole myriad. A lot of the papers looked at a myriad of demographic and radiographic findings and weren't able to find any association with age or other conditions that predicted symptom relief, right? And in terms of
in terms of the appropriate workup, so we were asking that amongst ourselves to see if we could make a recommendation.
It's not clear.
Unfortunately, none of the pediatric literature really comes out strongly about that. Some of the adult literature talks about various things they do. So repeating ultrasound is a pretty common thing to do. Some studies talk about repeating HIDA. Most of the adults that are getting worked up for this get an EGD, and oftentimes in conjunction, they'll do an endoscopic ultrasound, which is more sensitive for biliary sludge, which would then be an indication to remove the gallbladder in the appropriate pain setting. Sort of expert opinion among the people at the table, we think a GI consultation and probably an EGD and a really good symptom history, and definitely an ultrasound, and consider repeating these things is pretty reasonable. We want to put cold water on the idea that the HIDA scan is a yes/no for whether they have this disease. Plenty of other GI conditions can have depressed HIDA scores. Plenty of people that have true functional gallbladder disorder can have a normal HIDA score percent. CCK hurts. If you, like you said, if you give it fast enough, it'll hurt anyone. It also causes GI hypermotility, which can be confused for pain because people sort of have an uncomfortable feeling that comes along with that.
I think the other thing that we want to highlight is that you have to set reasonable expectations for, when you're having these discussions with the patients, right? Like so long as you have that discussion with them and you let them know that there is a chance you could improve with it, there is a chance you can improve without it. This is, not a slam dunk, despite the fact that the operation itself is pretty, low associated morbidity.
Yeah, I think our overall take of the literature is that biliary dyskinesia is probably a real thing, but we just have a lot of trouble. We don't have great criteria to decide who actually has it or not. In a third of the cases of these cholecystectomies, findings of chronic cholecystitis are found, on pathology. So something is going on, but overall we are probably over-treating since we have such a hard time figuring out who actually has it.
One last question.
Thank you for a great presentation. Jillian Jacobson from UT Southwestern. I was part of a group that published one of the hyperkinetic papers you all shared, and we also looked at normokinetic biliary dyskinesia, which wasn't included, but one of the things that we found was the definition of pain with CCK is so variable. And so in our cohort, we found that the kids who had reproducible right upper quadrant pain with biliary dyskinesia had symptom relief after cholecystectomy that was sustained at their 2-week visit, and again 4 to 5 years later when we followed up, whereas kids with diffuse abdominal pain with CCK administration didn't have relief at their 2-week visit and still didn't have relief at their 4 to 5 year visit. And so our attendings had changed the way that they counsel. But I was wondering if in the papers that you all included on normokinetic biliary dyskinesia with pain with CCK administration, if you were able to parse apart whether that pain was truly right upper quadrant pain, the pain that brought the kids to the office, versus diffuse abdominal pain simply because, as you were saying, CCK hurts.
I don't think the data was that granular to make that decision, which is why our recommendation is not to use CCK as an indication for the operation.